gives me great pleasure to introduce my co-chair, Dr. Timothy Lai, who will also talk to us on a subject that's in a little bit of controversy now because we are detecting it more and more often, non-exudative choroidal neovascularization.
Okay, good morning everyone, and thank you Muna for the invitation, and it's my pleasure to come back to India and talk about today it's on this session is actually on controversies of medical retina, and I'm talking on non-exudative CNV. So these are my disclosures. So what's non-exudative CNV? So this is a CNV that grows into the subretinal RP space without any leakage of fluid or blood. So you can see healthy retina on the top, and in the non-exudative stage, you only get the elevation of the RP slightly because of the CNV growth, but there's no subretinal fluid on top. So these cases are usually asymptomatic without causing a visual loss, but it has the potential to progress into the exudative form, which can cause visual impairment. It's mostly associated with AMD, but can also be associated with other diseases like CSC, PCV. These are pachychoroid diseases, android streaks, hereditary retinal dystrophies, ocular inflammation, or uveitis. So these are some examples. So here you can see on top, there's a patient with RP. You can see the diffuse reduced autofluorescence in the fundus autofluorescence. On top, you can see a CME associated with it. In the bottom, you can see FA didn't show a leak, but the OCT showed this lesion, a CNV lesion, which didn't have any exudation before, back in 2017, and then 2 years later, it started to exudation. These are some examples in pachychoroid CSC condition. You can see the top ones are those with subretinal fluid. So these are pachychoroid neovascularization with leakage. In the bottom, you can see these basically the non-exudative CNVs. Here's a case of ocular inflammation. You can see some scar with the OCT showing the CNV, but without any exudation. So what are the controversies for this topic? So firstly, the nomenclature. So how should we term these lesions? So these CNV has actually been described for a long time. So back in the 1970s, it's been shown in the histology of these postmortem eye with the AMD, which actually had a CNV but without any exudation. So should these be called subclinical CNV, quiescent CNV, or non-exudative MNV? So the Conan study group, this is the nomenclature study group, say they recognize this non-exudative MNVs as a distinct clinical entity, but it did not reach a consensus for further subtyping. So they actually suggested to discontinue the term quiescent because we really do not know the cutoff time required to determine whether this is a new CNV versus a mature CNV which is not leaking. Second controversy is the pathophysiology. So exactly why these develop is unclear. So there are two hypotheses. So the first one is that you get this stable non-exudative MNV which can reduce the progression rate of the RP atrophy. This may provide some nutritional support to the overlying RP or photoreceptors, and this is actually supported by the histological features of these lesions, which is quite similar to the normal choroidalis. The second hypothesis is that these are actually CNV which developed and progress as develop and represent regressed new vessel as seen in the experimentally induced CNV lesions with or without leakage. So there are some good papers. For example, there's a very nice paper from Armani Fossi's group. They looked at these patients' progression of the subclinical or non-exudative CNV, the baseline, and follow these patients and compare the rate of GA growth with or without subclinical CNV. And you can see that with those patients without the subclinical CNV, they actually had progression of GA a bit faster. But a few years down the road, Phil Rosenfeld, they did another study. They looked at 9 eyes with geographic atrophy and the non-exudative MNVs and followed for at least 1 year, and they measured the growth of both the MNV and the geographic atrophy growth rate. And they actually did some correlation analysis, and only one eye showed a significant but rather weak correlation between the GA growth rate and the MNV. So they actually concluded that the results are not consistent with having a non-exudative type 1 MNV having a strong inhibitory effect on the local growth rate of the GA. Third controversy is the diagnosis of non-exudative CNV. So these, traditionally we use FA as the gold standard of defining a CNV, but they do not leak because they are not exudating. So that's why we cannot use fluorescein angiography to diagnose them. So another choice is to use the ICGA, which actually can show the plaque in the late phase, but it's not widely performed, so the exact accuracy is not clear. OCT is actually very popular, so every retina specialist is using it, and you can see these non-exudative CNV as slightly elevated RPE detachment, or also called SHRI, which is shallow irregular RPE elevation, and this is defined by having a double layer sign with a non-homogeneous internal refractivity, and the RPE elevation has to be at least 1,000 micron in length and also less than 100 micron in height. So some of these smaller CNV, however, if they are less than 1,000 microns, you might not be able to detect it with this definition. So here's an example. So you can see elevation of Brooks membrane, and then you can see RP is slightly elevated, and you can see double layer sign with the MAV in between. So OCTA show it quite well. So that's why OCTA is now the investigation of choice for these cases. You can detect the flow signal of the blood particles inside the blood vessels, but there are potential issues with the artifacts and also potential rate affected by the protocol and the scan time. So sometimes the flow inside the non-exudative CNV is very low, so you might not be able to pick it up with the OCTA. Another controversy is the treatment. So how should we treat these patients? So if you look at the literature review, so the natural history of these cases, they generally progress not too quickly, but still a substantial proportion. So here, patients were followed for 6 to 12 months. You can see a rate from 6% progressing from the subclinical or non-exudative CNV to exudative type, about 25%. So about up to a quarter of them can progress within 6 to 12 months. And if you look at another longitudinal study, you can see these patients, 6 of the 53 eye without any CNV, they changed from dry type to the wet AMD or exudative CNV. But in those already with a non-exudative CNV, 80%, 8 out of the 10 eyes developed the exudation. So there's an 18-fold increase rate of exudation. So here are some examples with progression on the left side. They did the OCTA OCT every 2 months, and at the 8th month follow-up, you can see exudation started to develop. Left side also initially didn't have any MNV, and then baseline you can see this lesion, and then 4 months later develop the exudation. So one strategy is to use anti-VEGF regular injection to prevent them, or the other is to just basically observe them and treat them with if there's exudation. So Clement Chan actually performed such study called the PREVENT study in the States, and they looked at the use of prophylactic ranibizumab treatment every 3 months compared with sham injection in these patients with non-exudative AMD. So these patients actually, if you injected them, they show there's no difference in the conversion from dry to wet AMD. So in about 8% of eyes still develop this subclinical CNV regardless of whether in a sham or the ranibizumab treatment. So prophylactic treatment is probably not useful. Some further directions, so we can consider using AI to help us to detect these lesions. So you can see these lesions are very small, and you have to go through the scan one by one, which is quite time consuming. And with artificial intelligence, they actually achieve very good results comparable with expert graders. And you can also use the deep learning AI models to see whether some of the lesions are high risk or not. And by combining the OCT and OCTA findings, they actually perform better than human performance. And now currently a prospective study is being conducted in UK NHS. They will look at 800 patients with new onset neovascular AMD in first eye, and then look at the prevalence of these non-exudative MME in the fellow eye and the rate of conversion. So to conclude, so non-exudative CNV is a distinct clinical entity in AMD and many other retinal conditions. Multimodal imaging, especially OCTA, is very useful for diagnosing them. Though these patients should be monitored regularly and treated with anti-VEGF when signs of exudation start to develop. And in the future, artificial intelligence with deep learning is going to be useful for us to diagnose these cases as well as predicting the early activation of the lesion. Thank you very much.
Thank you, Dr. Lai, for a very insightful talk. Are there any questions from the audience? Yes, Dr. Lai.
Fabulous talk, team. May I know, is there a recommended follow-up interval for these patients with non-exudative AMD?
Thank you very much, Dr. Hang. So you really don't know when they occur, when they develop. So I would recommend maybe every 3 to 4 months. Some people say 2 months, but maybe that will overburden ourselves. So I think 3 to 4 months, up to at most 6 months. But it also depends on the fellow eye status. If the fellow eye already has a scar or having regular injections, these patients would need to come in anyway. So then these patients can be followed a bit closer.
I have a question on the idea of treating versus observing. I think all of us now decide to observe these patients. Would your threshold be different if the other eye has been lost due to advanced neovascular AMD?
I think I would still monitor, but more closely. So as soon as they develop new symptom, then I'll start treatment and ask them just come in, call my clinic immediately. And then also every time they come in, I also examine the fellow eye because they will be coming in for example, T&E treatment for the fellow eye. And then I would definitely scan and look for any non-exudative CNV or any signs of exudation in the not affected eye.
Do you have any branching patterns or algorithm to tell whether this disease will progress or it will remain quiescent?
Sorry, I can't hear you.
Do you have any AI-based algorithms available in the market?
Okay, thank you very much. Very good question. So AI, they are still doing study at the moment. So not commercially available, but of course, in the future, hopefully we can have some tools which will be useful for retinal specialists.
No, will it predict whether it will progress?
Yes. Yes, yeah, that's what the last study I mentioned about. So they will look at the features of these MNE, for example, elevation of the Shri, and also the OCTA, what kind of pattern the lesions are, and then that might help you to predict which is going to be leaking sooner or later.
And diagnosis is only based on OCTA, or you diagnose it on OCT also?
OCT and OCTA, I use both. Yeah. Thank you.
Thank you very much.